Today, what we're going to be talking about is recognizing occlusal stability. So not just recognizing occlusal disease like we talked about before, but really starting to expand your understanding of the key components of a good occlusion. And then when you start looking at patients, you can start to see if those qualities or if those key components are present or not. And then if they're not, is that causing a problem? Remember, occlusion, this topic is about force management. And the good news for us is there are ways that we can arrange the teeth, that we can make the teeth fit together, that we can make the teeth occlude and disclude and allow us to manage force. And when we can do that, we can be incredibly predictive with the types of treatments we're doing, whether it's something very simple or whether it's something that is more complex. So let's go through the Dawson requirements of occlusal stability, and you're going to find that these are very similar to what you're learning. I just want to go through them quickly again so that when we look at our patients that we can start to see whether those are present or not. One of the interesting things to look at is this technology that we have from Sirona that allows us to digitally scan the patient's mouth, do a cone beam x-ray, and to actually track their jaw as they're moving through their mandibular movements. And so when we gather this data, we can then make our CBCT or our cone beam actually move. And I want you to see this from a standpoint of understanding some of the movements that we're talking about. So remember, as we open our jaw, there's a period of time where the jaw rotates, the condyle rotates in the glenoid fossa, and there's a period of time when the condyle has to translate down the articular eminence. That allows us to get to maximum opening. People can rotate and translate simultaneously, or if we're going through the border movements, there'll be a period of time where we rotate for, say, 15 to 20 millimeters, and then translation will begin. So when we look at the mandibular movement, what I want you to visualize is that in an ideal occlusion, when the joints are seated, when the joints are in their fossa, that we should close and have maximum tooth contact. And we'll talk about stable stops or equal intensity stops in a second. But the other thing, if you want to remember, is that when we leave that home base of how our teeth fit together, we want to have disclusion. So as we go into a left lateral movement that we see here, notice that a lot of the force is out there on the canines and the lateral, and on the balancing side or the right side of the patient's mouth, the teeth are discluding. The enemy of a good occlusion is when back teeth rub. So also notice that when we'll back it up and look at it again, that when we go into that left lateral movement, how the non-working or balancing condyle has to come down the articular eminence. That helps in getting the teeth to disclude on the non-working side. We go into a right working movement, and here again, notice how the left condyle comes down the articular eminence, and how we want the force out there on the canine if possible. And in a protrusive stroke, we have both condyles. We get help from the condylar guidance as both condyles track down the articular eminence. And we have the contacts up front. Again, no ability to rub on the back teeth. So I just want you to have a good understanding of the mandibular movements. So as we go through our basic rules, these 5 requirements, number 1 is we do want equal intensity contacts. We want to have stability around the mouth. Whatever force the patient can generate, the more teeth that come together in contact, the more that force is going to be distributed throughout the mouth. 2 options in terms of how teeth can come together. You can have a cusp fossa type occlusion where the cusp tip fits into the fossa, or you can have a tripod contact where the cusp fits into the fossa and has 3 points of contact. I tend to use more cusp fossa, but they both work, and I just find that when I'm doing dentistry, getting a cusp tip to land in a fossa is what I'm shooting for. But that left picture is a good example a full mouth reconstruction where we've got all the contacts lined up. Even the lower incisors will find a place in that cingulum. So creating stable equal intensity contacts is what we want to do, and particularly lining that cusp tip, so we're going to be loading the tooth through its long axis. We want to avoid a cusp tip contact on an incline. That is not going to be stable. The second thing we want to look for is this concept of anterior guidance in harmony with the envelope of function. So as we leave our home base where everything's contacting, as we slide into a protrusive stroke or a left or right lateral movement, we want to make sure the back teeth disclude. So this concept of having the line up front, which means that as we go from our home base all the way out to our protrusive stroke, that there's going to be front teeth carrying that load in protrusion, and many times it'll just be the canine carrying the load in excursions. For many reasons that you'll learn about, we do not want back teeth to rub. So I think that we understand that anterior guidance is an inside-out movement. We get the help from the condylar guidance in the back as the condyles come down, and the contours, the concave contours of the front teeth are key to disclude the back teeth. The other part of this rule, though, is anterior guidance in harmony with the envelope of function. And I think you can have an appreciation that there has to be some steepness up front to create disclusion. But remember that envelope of function is the path that the lower incisor travels outside in. And that happens when people are speaking and when people are chewing. So it's possible for us to have that lingual concavity too steep. Orthodontists may move the teeth too far back in the way of that path. Restorative dentists are guilty of making crowns too thick back there, and we'll show you an example of that later when that happens. So second to getting the bite nice and even, getting the anterior guidance and harmony of the envelope of function is critical for success. And we'll teach you how to evaluate whether both are there. Concept that we want lines in the front and dots in the back. The rest of these, 3, 4, and 5, are really about creating disclusion of the back teeth. And so number 3 is disclusion of the posterior teeth and protrusion. So as we slide forward, we want the back teeth to immediately separate. The other thing we want is the disclusion on the mediotrusive side, or the balancing side. That's the same, mediotrusive and balancing. I know it's confusing, but both of those words are used interchangeably. But think about it this way. The mediotrusive side or the balancing side is the side where the lower molars and premolars are moving toward the midline. And so this is tricky because you need to get the longer upper lingual cusp to get past the longer lower buccal cusp. And we get help, remember, on the balancing side from the condylar guidance on that side. Look at the picture on the left and you'll notice as the lower jaw moves to the mediotrusive side, how that condyle has to come down the articular eminence. It's very important in making sure that these don't rub, because this is really one of the most damaging interferences that we see that increase muscle activity. Okay? The only other one that we would have is that we want disclusion on the working side, which we'll show you in a second. But why we want posterior disclusion is if people can rub on their back teeth, this is what excites the system. And if we can rub on back teeth, increasing the muscle activity is the thing that will cause teeth to get loose. It'll cause teeth to wear, and make no mistake about the fact that a lot of teeth break. We mentioned that it's not just because of big fillings that teeth fracture. The last one is non-interference of posterior teeth on that working side. We'll talk about times where we maybe want to have back teeth touching on the working side, what we call a group function. But for now, let's just focus on the fact that we really don't want back teeth to rub. And then we'll get into the exceptions to the rule later. Most of the time, this is what you're going to be shooting for. Lines in the front, dots in the back. So that top picture where you have equal intensity contact all the way around. And when we leave that home base as we go into excursions and protrusion, no ability to rub on back teeth. And what we find is that will create the most neuromuscularly peaceful system, which is what we are after. Let's look at a couple of examples, and I'm going to show you some examples from my friend Doug Knight, who's actually an orthodontist there in Louisville, who's done some things with us in the past at Dawson Academy. Does beautiful work orthodontically. But when we look at a beautiful smile, beautiful aesthetics, what we really also want to make sure is we've got good alignment of teeth. And so when you look at this, we can totally appreciate straight teeth. But what I really want you to focus on is how the canines are arranged. This is a Class 1 canine arrangement. And the great thing about a Class 1 occlusion is the position of the canines when it's proper makes it so that when we go into that excursive movement, that the lower canine is going to be tracking against the mesial of the upper canine. Class 2 patients with the lower jaw back, you can still get it, but I think you can guess that the more Class 2 somebody has, the harder it's going to be for the front teeth to engage. And so the problem with the Class 2 patient is often they are in a skeletal situation where the back teeth are just going to rub. And we'll talk about what we do about that later, okay? But this is a really nice example. Notice also how we have good contact. If we think about it from the transverse perspective, which means if you look at it from the frontal view and you consider the width of the upper arch versus the lower arch, notice the teeth are fairly upright, but the lower buccal cusp tips are fitting right within the fossa, okay? So we've got cusp tips landing where they're supposed to be. And notice when we look at the front teeth, how that the front teeth actually touch. They are engaged. There's contact there. If they are in contact, that gives us the ability to create posterior disclusion. And in fact, when we look at her going to a protrusive stroke, which is the bottom picture, notice how all the back teeth are separated, and we go into a left or right lateral movement, how the lower canine engages the upper canine and posterior disclusion occurs. That is the earmark of a really good occlusion. Another case from Doug, again, a post-op, somebody who's just coming out of the braces, their tissues are a little bit irritated. We'll see this in a few weeks after she's cleaned up. But what I want you to appreciate post-orthodontically is just what we've talked about, how we've got good contact in the front, how we have that good transverse relationship where the lower buccal cusps are landing properly. There's a correct amount of overjet and overbite so that we can actually have contact, appropriate contact, when we go into excursion. So this is the same patient a few weeks later after the tissues have been cleaned up. And again, notice Class 1 canine. That lower canine is engaging the mesial of the upper canine on both sides. And we have good contacts across the front, which again allows for good lateral excursions. Again, the earmark of a really good occlusal scheme. Take you before and after of one of Doug's cases, something that he may show you. But you know, orthodontists have a very difficult job, and you know, today with some of the clear aligner treatments, you know, as GPs we can do more of this. But treatment planning is everything on these cases. In a case like this, where the size of the mouth is just not big enough for the size of the teeth, making the decision to do extractions is somewhat controversial, but sometimes it has to be done, but it can't be done to compromise the face or the envelope of function, which we'll talk about in a little bit. This is extraction therapy done properly. And so notice how we have a nice relationship, again, of the canines being in Class 1. Notice how we have good overbite, overjet relationship up front. Beautiful result. And again, as you look at this face, you would never have any idea that she's missing some teeth. So, you know, extraction therapy is under fire right now, and it should be, because there's a lot of extraction cases that have caused airway issues and envelope function issues and things like that. But sometimes it is necessary, and this is a really nice example of when it was, and in a great profile of a good case. But again, the earmarks of a really good occlusal scheme here. Now let me show you one that appears to be pretty good. I want you to look at her smile, and you look at her face, and she does appear to have a little bit of a smaller lower jaw. But we are taking her through some of our treatment planning software to look at all the lines. And there's certain things that we look at to determine aesthetics, and a lot of this looks pretty darn good. But now I want to take you and have you look at her CBCT and the technology that we talked about before. Notice how she opens and closes, how she has a lot of kind of strange movement to her jaw. And as if you look at her right condyle is basically missing. She has severe degenerative joint disease in that right condyle. And because of that, the teeth really prevent the joint from seating up into the fossa, which means the muscles are really working overtime to try to keep things in alignment. As you go through this course, you're going to start to really learn about how important a stable seated condylar position is, and a healthy condyle. And so what I again want you to see is, if you don't have a stable seated condylar position, the home base is very difficult. So what I want you to look at here in this little video clip, and imagine that I'm holding her jaw as we're doing the jaw tracking, trying to get her joint seated. And as we go and open and close, notice how her front teeth don't come together. So she closes, she's touching that very back molar, and then skids into her bite. Let's look at it again. So here she's hitching, front teeth don't make it together. Back teeth are bumping, that back right second molar, and the skid. Some people call this a dual bite relationship. The joint relationship and the jaw to jaw, or the how the teeth fit together, are not the same. And that little skid means that back teeth are rubbing. She's grinding between a joint position and how the teeth fit together. It also makes it very difficult in excursive movements to get that done. The thing that we want to see is, when we look at her joint position, look at how far back her jaw is. So this is somebody who's skeletally class 2 because of a joint problem that makes it impossible for the canines to line up, which means you're going to have issues with the bite, particularly from the standpoint of our goal of having back teeth not be able to rub. Okay, so this is an indication that sometimes you can look at somebody's face, and when the lower jaw is too far back, you can almost imagine what you're going to see in the mouth and the potential for some of the occlusal problems that exist. Maybe you can even start thinking about some of the treatment modalities you might need to fix a patient like this. I want to revisit this concept of envelope of function. And remember what we said, the rule is anterior guidance in harmony with the envelope of function. And so as we go inside out here, the anterior guidance part is pretty easy. You want to have the front teeth excluding the back teeth. But the envelope of function part is a little more tricky, because how that lower jaw travels is like a fingerprint to each patient. And when we're restoring front teeth or moving front teeth, we have to make sure we don't violate that. Well, let's look at what can happen. If you have a restricted envelope of function, what I want you to think about is you may have had a patient that has a really pretty normal outside-in path lower incisal travels, which is what you see on the right there, that outside-in approach. But let's say the teeth were moved back, maybe premolars were taken out and the upper teeth were retracted, so they're very vertical. So the example would be maybe the teeth were originally erupted in the mouth like this, but they were crowded, so premolars were removed, and then an orthodontist moved the upper incisor to a position like this. So now when the patient functions outside in that envelope of function, that upper incisor is in the way. And what I want you to imagine is that that went on for years. Where would you see the damage? What potentially could happen? Well, those upper teeth could get loose, they could move, or they could wear. And a lot of times when we look at a patient that this has been done, and this is a side view of a patient whose premolars are removed and the upper teeth are retracted, notice we have those abfraction lesions, but we also have tremendous wear and tear on the linguals of the maxillary incisors, laterals of canines. Very little wear on the posterior. And so what I want you to think about is if lingual contour is in the way, this is that thinning or damaging that can occur if we are not in harmony with that envelope of function. This is an incredibly important concept as you move forward with your training, particularly when you start doing more advanced things. But it's even important when you're just doing a single front tooth, because you want to make sure that it is in harmony with both the excursive movements, protrusive movements, and lateral anterior guidance, as well as envelope of function, the outside in. So as we look at Vance, we can start to see this is a guy that wants his mouth restored, and he's unhappy with how things look now, as he should be. He's had composite placed on his front teeth that just comes off because the force has not been put under control. So what's exciting about what I do at the academy, both in my practice and what I teach other dentists how to do, are these types of cases that are a little bit more complex, and you're going to be learning from the beginning the tenets and some of the basic treatment planning principles that you need to know to do these kind of cases. And these are tremendously rewarding cases from the standpoint of just taking somebody who's on a path to lose their teeth and giving them a really good looking smile and one that's going to be stable. And we'll look at case examples in my video 5 with you, 4 and 5 with you. Think about the signs and symptoms of occlusal disease, the wear, mobility, migration, sore muscles, and the potential T&J issues. Pretty much all the signs of instability on this case is related to the dentition and the fact that the occlusion is not stable, primarily because of lack of harmony with the envelope of function. Let's look at one more, look at Raj. And again, Raj is somebody who is it's a really nice looking set of teeth, again, post-ortho. But Raj is suffering from headaches, doesn't have wear, doesn't have loose teeth, doesn't have teeth that are migrating. Joints seem to be nice and stable, but his temporalis muscles, the lateral pterygoid muscle, which is behind your eye, the master muscles are all very, very sore. And what we need to see is if he's got this soreness, is it related to his occlusion? And so what I want you to think about is we would do an exam, and this is sort of the summary: severe headaches in the temporal region several times a week. He's got normal range of motion. We can load his joints, but when we palpate his muscles, the medial pterygoids and the temporalis are the main ones that are extremely sore to palpation. A little bit with the masters as well, but no tooth wear, mobility, or migration. So when you think about this, what would you look for in his occlusion to see if you think increased muscle activity is his weak link. And that's what I really want to remind you that's so tricky with occlusion, is think about the different components of the masticatory system, the temporomandibular joints, the muscles, the teeth. You can have increased muscle activity, and remember, for the individual patient, it's whatever the weak link is that's going to become dysfunctional. In this case, teeth were strong. Apparently, they didn't have any wear or tear. His weak link was the muscles. The muscles got sore. And so what we're going to be looking for is just, is there something in the occlusion that tells us that he is a candidate for having some of these issues? You notice the distal of the left canine, how just a little teeny wear facet there and there, but nothing really to scream home about. But this is what I really want you to look at. This is his maximum intercuspation. This is how his teeth fit together in home base. And what I want you to notice is look at the canines and notice how the lower canine on both sides do not touch the upper canine. In fact, he's got a slight open bite from canine to canine. If we were to look inside his mouth and mark, he touches premolars back. But when the canines do not engage, when they're not socked in, even with a class 1 relationship, what that means is when he slides side to side, the lower canine not touching, back teeth are rubbing, and muscle activity is going to go up. Okay? And if he does that constantly, if he grinds and clenches, then that creates that consistent problem where muscle activity is higher. Now, what you would do in a patient like this is make sure that doing something the occlusion would help. So this is where bite splint therapy, putting an appliance in with an ideal occlusion to see if the headaches go away. If they do, then we know if we change this occlusion that we're going to have the same basic effect. So I think that's pretty logical to you. That's what we're looking for. That's what I want you to get used to looking. Look at those canines. Look at the anterior teeth and make sure that they're even in contact. If they're not, then we're in trouble right from the get-go. Second thing we do if they are in contact is put paper in there and just have them grind around and see if the back teeth are rubbing or not. That would have been my second thing. We put Raj on an articulator, and we'll get into this a little bit later, but it's even a little bit worse from the standpoint because he's also one of these patients whose jaws go back a little bit. Now, he has a good, healthy canine, but he just has a condyle that wasn't quite seated in the fossa. And that's something we're going to get into a little bit later in the class. But right now, I just want you to understand that you can have back teeth rubbing from not having good guidance in the front, whether it's on the centrals or up the canines. You also can get back teeth rubbing if the condyles have the ability to go backwards, either because of a poor anatomic relationship or because of a condyle that has changed. In this case, really good healthy joints, just a problem with just the positioning of the condyles in the fossa. So what I tried to do here today is give you some basic things to look at as you are looking at each other's mouths, and next year when you get to clinic or at the end of the year when you start looking at patients, to recognize the tenets of good occlusal stability. And so remember, as a general rule, when the patient closes their mouth, we want everything to touch evenly, and we want to make sure as we go into excursions that we have no ability for back teeth to rub. And then if you see wear and tear in the front of the mouth, start to look for the possibility of maybe restricted envelope of function. That's kind of where we want you thinking right now. As we move down the road, we'll also then add in some of the layers regarding the importance of joint health and joint stability. So I hope you found that easy to understand and somewhat entertaining. I know you've got a tremendous amount on you this year, but again, my hope is you will continue to appreciate this topic of occlusion and not forget how important it's going to be for the great career that you have chosen. So until next time, I'm John Cranham. Have a great day, and thanks for tuning in.